When Massachusetts enacted healthcare reform in 2006, they mandated all citizens must obtain health insurance. The biggest problem they encountered was that there were not enough primary care doctors.
If you took all the family docs, all the general internists, all the advanced practice nurses, and all the PAs, and you left all of them who are trained in primary care to practice primary care autonomously, still not enough bodies. With the aging population, the amount of need, and the disease that's out there, there's still not enough bodies to take care of everybody.
As we begin to look at strategies for health reform, we need to take a close look at our healthcare workforce and ask ourselves the question, what kind of workforce does America need to serve all of its citizens?
We have a similar number of physicians as most other countries. However, our workforce is made up of about 2/3 specialists and 1/3 primary care physicians. In contrast, in most other industrialized nations, primary care physicians typically make up about half of all physicians.
Barbara Starfield in Health Affairs published her research showing that for each one increase in primary care physicians, you have better outcomes. If you have the same thing with a specialist, your outcomes go down.
A growing body of literature has demonstrated that a strong focus in primary care is associated with better population health, increased access, decreased total cost, and reduced healthcare disparities. Even within the U.S., regions that have a more balanced ratio of primary care doctors to specialists are associated with better health at lower costs.
Access to primary care gets patients in earlier, treats diseases sooner, and makes sure preventive care is provided. That's what increases longevity more so than the technology.
The World Health Organization recently came out with a report, Primary Health Care Now More Than Ever. This report describes the major shortcomings of healthcare delivery. Inverse care, impoverishing care, fragmented care, unsafe care, and misdirected care. Perhaps nowhere are these shortcomings more evident than in the United States. For instance, there is an enormous gap between the health of the rich and the poor that appears to be widening. This is because typically the people who need care the most are the ones least likely to get it. Also, 2 million Americans are involved in bankruptcy each year due to catastrophic medical expenses. Compared to other industrialized nations, the United States scores poorly in terms of care coordination, community orientation, and comprehensive care.
When patients don't have access to primary care physicians, they're going to seek episodic care with a specialist when they have a problem, instead of trying to do the preventative medicine that they would be able to do with their family physicians.
At least 44,000 people, and perhaps as many as 98,000 people, die in hospitals each year as a result of preventable medical errors. And because of supply-sensitive care, we have excessive and unnecessary utilization of certain medical services. At the same time, 37% of all adults and 42% of those with chronic conditions routinely skip medications, fail to see a doctor when sick, or forego recommended care because of the cost.
We also need to pay for care coordination in primary care offices. Care coordination involves keeping all providers on the same page regarding a particular patient.
The patient-centered medical home is a model of improving primary care that incorporates enhanced access, care coordination, and also team-based collaboration.
I'll have people who come and see me for back pain and say, well, maybe I have a kidney stone. Well, I'll work them up for that, and I'll either rule it in or rule it out. But then that patient's kind of left hanging after that. Where do they go from there? And if they have primary care, it's usually back to the primary care physician to plan the next step. But often patients don't have that primary care, so then their next step is they're calling up the orthopedic surgeon, to check their back, or they're calling up the gastroenterologist because maybe it's something in their bowel. So when you start seeing a whole bunch of specialists, everybody zooms in on their area, but you need to look at the overall picture of the patient.
That's what the primary care medical home does. It makes sure that there's somebody watching out for everything, not just the organ-specific problem, because the treatment of one organ can cause a problem in another.
Medical home demonstration projects are currently going on in almost every state in the country, and preliminary results have been quite promising. For instance, incorporation of the practice model in North Carolina Medicaid saved the program $124 million in 2006, in addition to improving the care of Medicaid patients.
The evidence has shown us that a good healthcare system has as its foundation a strong primary care. We must support primary care offices in being able to provide comprehensive lifelong care that includes prevention and chronic disease management, as well as patient education and empowerment. We must also realign the incentives to increase the number of medical students choosing to go into primary care, so that we can have a sufficient workforce to take care of our entire population.